I'd like to welcome everybody to this special panel that we have today on innovation in oncology. When things don't work in oncology, and they still very often don't work the way we want them to work, people are asking again and again, what could we fix? What could we change? How could we accelerate it? I don't think there's ever been a period that has seen this much innovation in any scientific area as we are seeing today in oncology. So the Biden Cancer Initiative has organized backgrounders on important topics, and this is the backgrounder on innovation in oncology. So our next and last speaker is Viktor Adalsteinsson. He is the group leader of the Blood Biopsy Team of the Cancer Program here at the Broad Institute. Viktor asked a very basic question. He said, we can learn so much from surgical biopsies of cancer patients, but we can't get them because we can't go back in to get biopsies and see how cancers change over time. What can we do about that? Is there some alternative? And Viktor and his team here at the Broad have been working to ask, can we learn everything we can possibly want to learn, not from a surgical biopsy, but from a simple blood draw, a blood biopsy? And Viktor is going to tell us about that work. And before he does, I'm going to tell you that Viktor's secret is that he is half Icelandic. You can, as he gives his talk, see if you can figure out which half. Viktor.
Great. To enable precision medicine, it must be possible to routinely sample and sequence patients' tumors. This will enable us to give the right treatments and closely monitor responses, to figure out where the cancer is headed, and to correct course before it's too late. Yet surgical tumor biopsies are often not feasible. They're invasive and painful, they carry risks for complications, and they're particularly challenging when tumors are in difficult to reach locations, such as within vital organs or the brain. One potential solution is to profile the tiny bits of DNA that tumors release into the bloodstream, which is called a blood biopsy. And in contrast to a surgical tumor biopsy, a blood biopsy is easy to obtain routinely and repeatedly and may reflect multiple tumors throughout the body. But whereas most blood biopsies profile select genes, we wanted to see, could we profile all genes in the cancer genome from blood to figure out why some patients respond to therapy and others don't, and which treatments might be best to give. Just a few years ago, this seemed like a crazy idea, but the team has made significant progress. We've established that a blood biopsy reflects the majority of genomic information, as in a surgical tumor biopsy, by comparing 41 matched pairs of both, and not looking just gene by gene, but throughout all protein coding regions of the genome. But since the levels of tumor DNA in blood can vary substantially, we reasoned that being able to know ahead of time, before extensive sequencing, how much tumor DNA is in the blood would be an important part of making blood biopsies feasible at scale. And so we implemented an approach which involves a trivial amount of sequencing to effectively count the number of copies of each gene in the genome. Here we can see in a healthy donor a relatively uniform number of copies, whereas in the blood of a cancer patient, we can see several regions of the genome that have extra or fewer copies of each gene. And we use these deviations from normal to figure out if and how much tumor DNA is in the blood. And applying this technique to over 1,500 blood samples from 500 patients with metastatic breast or prostate cancer, we find that a significant number of patients have greater than 10% tumor DNA in their blood, and even more have greater than 3%. We're currently focusing our analyses today, our comprehensive analyses, on those with greater than 10% DNA, but as technology improves, it should become more and more feasible to profile patients with less and less tumor DNA in their blood. So our data suggests that routine and comprehensive profiling of cancer genomes is feasible from blood. And we're now using blood biopsies to profile thousands of patients with drug-resistant tumors to understand why their treatments are failing. Because if we can use blood biopsies to figure out why some cancer cells respond to therapy, but others don't, maybe we can find better ways to treat the entire cancer and to prevent it from coming back. And recognizing that most patients with advanced cancer develop it months to years and sometimes decades after initial treatment, we reasoned that if we could detect cancer recurrence sooner, we might be able to treat when there are far fewer residual cancer cells within the body and therefore fewer drug-resistant cells to deal with. And so if we could treat early, could we potentially prevent patients from going on to develop advanced cancer in the first place? There's compelling evidence in the field to suggest this could be feasible. Here we can see that by looking broadly at many tumor mutations in a patient's blood over time, that indeed we can see signs of tumor DNA after initial treatment and years before recurrence with metastatic cancer. We're now validating these findings in larger cohorts. We're even planning a prospective clinical trial to test our ability to detect cancer recurrence early and to intercept it with further treatment. And we believe that understanding the detectability of post-treatment residual cancer in patients with confirmed diagnoses who either do or do not go on to experience recurrence may also inform both ongoing and future efforts for early detection of cancer in otherwise asymptomatic individuals someday. I'd like to acknowledge the many contributors to the work presented today. I'd also like to acknowledge the broader blood biopsy team involving scientists, engineers, medical oncologists, and computational biologists spanning multiple institutions who have come together to work on these challenges in a serious way. Thank you.